In the liver world, we often have pushback from patients when we advise them of how to help themselves make themselves better. And with fatty liver, that's particularly true because the mainstay of therapy for most of the patients happen to be lifestyle modification. Not only do they have to change their diets and eat well if they have type 2 diabetes mellitus and take medications for that, often see an endocrinologist for help with management. They also have to have dietary changes that help hyperlipidemia, and most importantly, weight loss. As mentioned previously, up to 10% weight loss is very helpful in the treatment of steatohepatitis, MASH, and even in patients that have fibrosis. So to help people try to lose weight really requires a significant commitment on their part because it's hard to lose weight. And the older you get, the harder it is. This often requires management with a multidisciplinary team, with nutritionists and social workers, perhaps in some occasions. So you do get pushback because patients ultimately often don't like doing the difficult work it takes to lose weight and control diabetes and control lipids well. So you need to support them as a provider. You need to provide support to them. You need to get buy-in from them. You need to let them know that they can help themselves so much if they can change some of their lifestyle aspects, the way they have conducted themselves, that they can help themselves be healthier, feel better, improve their energy level, and improve their long-term outcomes. Monitoring patients is very important. Healthcare providers all know that, whatever it is that you do or specialize in, and it's very important in my world as well. For fatty liver, remember, most of them do not have advanced liver disease. We think 5% of patients have or will soon have cirrhosis, but the vast majority of people don't have fibrosis yet. We want to help them avoid the development of fibrosis. So it's important not only to provide recommendations for their health care and for their lifestyle modifications, but it's important to follow them and see if they're doing what it is that will help them and what you think is a good idea for them to do. So we usually see patients with fatty liver, if they have no advanced liver disease, once or twice a year. We check their blood tests. We check once a year a fibrosis assessment of their liver to see if they are developing fibrosis, if they didn't have it already, and try to encourage them again to either continue or to start finally some of these important lifestyle modifications. Now, if people do have advanced liver disease from fatty liver already, then we follow them at least twice a year with blood tests and imaging procedures if they have advanced liver disease, because patients with cirrhosis are all at risk for hepatocellular carcinoma. This is another pearl, not only just with fatty liver. If you have any cirrhosis patients in your practice, even if they feel great, even if they look great, even if their labs look great, they are at risk for liver cancer. And it is the standard of care that every 6 months they get an ultrasound to look for liver cancer. And we usually also get a blood test called alpha-fetoprotein, AFP, twice a year. You should do this in your patients because patients will get liver cancer. And like any cancer, if you identify it early, you can save their life. We can deal with it. If you wait till it hurts and then they present and then you look for the problem and you identify a large liver cancer, unfortunately, the prognosis is very poor. So we see patients with advanced liver disease in my world at least twice a year for blood testing, liver imaging, and discussions again about lifestyle modification. The estimates are, in the United States, the umbrella of hepatic steatosis, of whom a small number actually have progressive liver disease. The overall umbrella affects 90 to 100 million people. Gastroenterologists and hepatologists cannot take care of all of these patients. We cannot. Primary care will have to assume the burden of caring for a lot of these patients. So who does need to come? Who should be referred to gastroenterology and hepatology? Patients that have elevated liver enzymes, the component of patients that do, they should come to us because we need to rule out other liver diseases. Patients can have fatty liver and a second liver disease. And number two, patients that have fibrosis, significant fibrosis. Those patients should come to us because we manage the liver cancer screening. We manage aggressive therapy for these patients. We determine if they're eligible often for medications that would be helpful. Those are the two groups. That's only a fraction of the patients, though. The rest probably should stay under the umbrella of the primary care provider. So the primary care provider needs to identify fatty liver, usually with an ultrasound. If the liver enzymes are normal, they may keep those patients, but what they also need to learn is how to do hepatic fibrosis assessment, either with a blood test or an elastography procedure like ultrasound with elastography or transient vibration-controlled elastography. Those kinds of tests can be ordered. You determine if a patient has stage 2 or 3 or 4 fibrosis. Stage 4 is cirrhosis. And those patients come to gastroenterology or hepatology. The rest stay with you. And you advise lifestyle management. You recheck the labs down the road, including a fibrosis assessment again every year or two. And then you are able to handle the vast majority of patients that have steatosis and keep them from developing progressive liver disease. So only a fraction in the end come to the gastroenterologist or hepatologist. When patients are on resmetirom therapy, they have at least stage 2 or 3 fibrosis. And as I mentioned, in a placebo-controlled study, it was shown that this product, compared to placebo, had a highly significant benefit for resolution of hepatitis and improvement of fibrosis. Now, do you stop therapy or do you continue it? It is a big debate in the world of the gastroenterologists and hepatologists. Most of us think that even if a steatohepatitis resolves and fibrosis improves, that this is a metabolic disorder. The problems that lead to fatty liver continue. Patients continue to have type 2 diabetes mellitus. They continue to have hyperlipidemia. Many of them may or may not have lost some weight, but they still may be overweight. So for the most part, key opinion leaders like myself think, at least now, that patients that are on resmetirom, even if the therapy is successful, they should continue on the medication over the long term. Now, if a patient gets worse on the medication or has a side effect from the medication, which is very uncommon, of course, those are patients you might discontinue the product. But if it's working, most of us think because of the metabolic nature of this disease, that patients will remain on the drug. In the liver world, managing third-party payer issues to help optimize clinical outcomes is a whole field in and of itself. And I'm sure for those of you out there that are providers in other subspecialties and in the primary care world, you see the same thing. My staff is very helpful. My nurses, my advanced practice practitioners, specialty pharmacies can help a lot of times. I think they're underused around the country. They can help you help your patients obtain medications that they otherwise have difficulty obtaining. It doesn't always work, but it helps a lot. It takes a little extra effort, though, on your part, on the provider's part, because you need to recognize and help patients recognize that if they can't get a product, that they can call your office and that you can help them sometimes get a medication that will greatly benefit them. Again, we have in our field many medications for expense or for other reasons that aren't initially approved. But when we help the patient and provide them resources that are different in every area of the country, we help patients get the medications that will help them. So please keep that in mind too.